Dr. Jeffrey Gollish is a world-renowned medical leader and advocate for continuously improving the patient journey throughout their surgical experience and for improving timely access to care. From 2006 to 2018, Dr. Gollish served as the medical director and head of the Arthroplasty program at Sunnybrook's prestigious Holland Orthopedic and Arthritic Center. During those 12 years, Dr. Gollish pioneered and developed several innovations, such as the first digital patient engagement program for total hip and knee replacement patients, and the Central Intake and Assessment Center, a new model of care to help manage rapidly growing orthopedic surgery wait lists. This central intake model of care also led to the development of the role profile for the Advanced Practice Physiotherapist, or APP, and has since been broadly adopted in various jurisdictions across Canada and elsewhere, thanks to Dr. Gollish's leadership with Health Quality Ontario. Dr. Gollish also served as the chair of the National Standards Committee for the Canadian Orthopedic Association and was an active board member from 2015 to 2020. He was also a longstanding member of the CJRR National Advisory Committee from 2010 until recently in 2021. Throughout his illustrious career, Dr. Gollish contributed several position papers published by the National Standards Committee and the Canadian Orthopedics Association, and was awarded many times for his excellence in leadership, teaching, and most recently received the 2020 Canadian Orthopedic Association Lifelong Service Award in recognition of his years and breadth of service to the COA and its members. To this day, Dr. Gollish continues to champion the role of the APP and team-based models of care amongst his colleagues and decision makers across Canada. We are very excited to have Dr. Gollish on the show today. I can't wait to dig in. Dr. Gollish, welcome to the show.
Thank you. That's quite the introduction, but thanks for inviting me. Happy to be here.
Dr. Gollish, so thrilled to have you here. Thank you for taking the time.
Well, that's great.
Amazing. So Dr. Gollish, obviously from the bio, we can all deduce, you were really a pioneer of innovation while at Sunnybrook. An example that we introduced in the bio was this regional assessment program where an advanced practice physiotherapist would basically do a protocol-driven assessment to determine if a surgeon consultation was needed for a patient. And so I'm curious, how did the Holland Center develop a culture that is so eager to try new innovation and innovative models of care?
Well, it's a long process. You've got to start with something that really needs to be changed and show that you can work through that process in a sort of traditional sense, a traditional model, changing that model before going to something that's very different from the traditional model, like the Central Intake and Assessment Center model. So, one of the first things that we did, going back to the mid-90s, but quite a long time ago, just we were looking. I worked with a master's student from Queen's University looking at patterns of care in orthopedics in Ontario and looking at particularly lengths of stay following joint replacement. And, go back through history, things seem somewhat, you can't actually imagine that these things happen. But so we found that basically people, the average acute length of stay in 1992 to 1994 was about 2 weeks, and in the Toronto area, about 80% of people went to rehab for another 4 weeks. So they were spending about 6 weeks in hospital. So once we had all that data, several of us at what was then the Orthopedic and Arthritic Hospital said, this is silly. There's no reason people need to be using all this healthcare resource. And we developed a program, a streamlined program at the Holland Center, the Orthopedic and Arthritic at that time, where we reduced the acute length of stay to 5 to 7 days. And then we had some innovation funding from the ministry, allowing us to set up an in-house rehab unit that we called the FIT program, Functional Independence Training. And the average length of stay there was 5 to 7 days. And when we compared the quality of outcome of our patients in the shortened program to those that went to the rehab hospitals, it was equally good, if not better. So once we sort of established that, and over the years as we moved through things, the hospital became accustomed to trying to move things forward. And the challenge there, and we'll probably maybe talk about it a bit later as well, is not only having your colleagues, not just the surgeons, but the other care team providers on board, but also the administration understanding that, we're trying to move in a different direction. So Luckily for me, over time, many of the people that were around in the 90s continued to be at the hospital over the next couple of decades. And so we built on that early success, and they were open to thinking about more innovative approaches to management as time went along.
Like a snowball effect.
Sure, go ahead, Alan.
I was just commenting, it's like a snowball effect once that early success comes in, and it just kind of rolls from there.
Yep, it's often the challenge is getting that early success, and having everybody feel it's a success and that you're doing something very different, and establishing an early reputation for innovation, and then the hospital wanting to continue to be a model for progressive innovation and improvement in quality of care.
Dr. Gollish, I mean, you could have just stopped there at the Holland Center, but, yourself and your team have gone out over the years and, shared your innovative models of care with, other jurisdictions, other organizations at, provincial and national levels. What do you think motivates that desire to spread kind of new best practices to other groups? I mean, you don't have to do those things. I'm guessing you do a lot of that, frankly, on your own free time.
Yeah, it's a lot of it's just done because you want to do it, and I think that was really it. I mean, we just looked at how care was being delivered, what we thought could be achieved in terms of improvement in efficiency, improvement in quality, some cost savings, and so on, and it just became sort of a passion of our team to try to see how much better we could do over time. And once you have that feeling as a team that you don't rest on your successes or your laurels, you go, okay, well, we achieved that. What's our what can we do next? What else is there that we can do that's going to really make a difference? And sometimes you succeed, sometimes you don't. But at the end of the day, it's a team approach to having to be willing to move forward and look at different things on a regular basis, and not just say, okay, well, we did that. That's it. We don't need to do anything else.
Did you find that sort of that culture around, being very forward thinking, progressive, innovative, was that something that, like, when someone new joins the Holland Center, did that just become contagious to them? Or was it more that the Holland Center attracted, new team members who had that, those innovative values in their culture already? Like, how much of your success do you attribute to attracting the right people versus making innovation contagious inside the Holland Center group?
Well, it's a bit of both, but I think that as we moved forward and people saw that we were becoming successful in achieving the objectives of our changes in care model, that it was attractive to them as well. And they saw that, that the center had a good reputation, not just for innovative approaches, but for quality of outcome of procedures. And the other thing, of course, is when you're looking to bring people on that are interested in your model, you want to understand that they're also willing to contribute to further innovation, that they're not going to say, okay, that's enough. I like your model, don't change it anymore. It's basically, I like your model. I'd like to come and work with you, and I'd like to try to help to move this forward and make it even better. So it really has helped us over the years to attract really some excellent staff that have been very, very successful in their own right in different areas of innovation.
It really comes as no surprise that you were one of the first orthopedic programs to adopt digital patient engagement, and your specific program was called My Hip and Knee app. I'm curious, why was this digital innovation so important to you?
Well, the challenge for us as a very high volume institution became one of how to help patients to continue to improve post-surgery without having to bring them back repeatedly for visits, and not overload our system. So when you're doing, over 2,000 joint replacements a year, and if you multiply that by the number of follow-up visits and then extra visits, et cetera, it quickly becomes a major challenge to see people when they have questions.
Right.
What became obvious, really over time, was that the questions that people had as they moved from their discharge day to their first follow-up visit, which in our model was at 6 weeks, was that the questions were very common, and they fell into common categories. And rather than somebody having to call the office and ask the same question to one of our assistants over and over, or we be saying the same thing, it was like, okay, there must be some way that we can manage this. There must be some way that people can help to navigate their own care safely, and giving them some guidance in terms of, when they're in trouble, to do something more aggressive, like going to emerge or something like that. So it was really a matter of looking at efficiency of utilization of time on both the healthcare team and the patient to say, I think we're kind of wasting time and of course, healthcare dollars, because every visit, costs money. So, the digital platform, and looking at that as an up and coming way that people were starting to access more and more, looked like the way of the future. And it turned out to be.
And I think, for folks who don't know, when we started this journey with Dr. Gollish and your team at the Holland Center way back when, I think I'm looking back at my old emails, it was, back in, I think, so if it's Dr. Gollish, we actually first met, I'm looking this up, in February 2014. So can you believe it's been a bit over 7 years? Wow, it doesn't feel like it. I don't know about you, it doesn't feel like it for me. And I think the thing that really amazes me is, nowadays, if we talk to another healthcare organization since COVID, this seems like an obvious thing to do for patients. But what's really blown my mind is, 7 years ago, your team was already thinking about this. So, I think that just underscores how forward thinking your team and the Holland Center have been, which is just phenomenal. So I'd love to know at some point your predictions for 7 years from now, because maybe we'll be able to catch the next wave with you. So, but anyways, I did want to highlight that. But one other thing that came to mind for me, and Dr. Gollish, I don't know if you remember this from back then, but when we first started together, we had a very patient-centered design process that we went through with your team. So for folks who wouldn't know this, we would literally, sit down at the Holland Center with patients in the waiting room who maybe were preparing for their hip or knee replacement, or maybe are just after it and doing rehab. And we would sit next to them and we'd show them designs of my hip and knee, and even on a paper-based version, find out, which button would they click, so that we would know how to design different interfaces for patients. So what I've loved was that the Holland Center had a very patient-centered approach. We didn't just design this on our own with your team, the clinicians, and then just give it patients in an app. We actually sit down next to them on paper and mapped it out together, I think. And so have you always been that patient-centered, or where did that sort of come from, that approach?
Well, yeah, we've always been like that, because at the end of the day, if you develop an intervention or an interaction that patients see as either unfriendly to them or biased or exclusive, or, then your team and you are kind of wasting your time, because people won't get on board. They won't want to use it. They won't think that you are developing something that's really going to be helpful to them and that they can use. And so, it was always important to us, even when we were developing the Central Intake and Assessment Center model, trying to understand how that was going to benefit people. What did they like? What didn't they like? How could we make it better so that it was helpful to them and to us and to the rest of the team? So that patient-centered approach is really critical. And I think it's interesting, Josh, when you talk about 7 years ago, it's gone by in a flash. But when you look at where you started from and say, 7 years ago, developing this platform with us, and it was has always been a great partnership and continues to be. You were learning as we were learning, I think, is what it comes down to. A lot of what people take for granted now, in a sense, and with your success and all the different providers that you work with, it wasn't always that way, right? And trying to understand sort of how do we work with patients? How do we provide a platform that is user friendly, that patients find is helpful to them, that the providers find is helpful to the patients. So there's been an amazing amount of progress in the past 5 to 7 years, quite frankly. And we were glad to be at the leading edge, and quite frankly, glad to be working with you, because when working with your team, you understood what we were looking for. And I think when we first talked about it, it seemed like maybe way more than we were biting off too much. But at the end of the day, it worked out, and I think it's been tremendously successful. And I know that lots of other places have modeled after this, and Seamless has been a tremendous partner for us in terms of moving forward and adapting the app, making sure that it is more user-friendly, looking through feedback from the patients that we get, and trying to make this patient-centered, friendly, useful approach for them.
Well, thank you, Dr. Gollish. I appreciate you saying all that. It really means a lot to us. I also wanted to highlight your team were very early leaders in the importance of video for patients. So for folks who haven't seen this on my hip and knee, with the Holland Center team, your physiotherapists actually filmed themselves doing a lot of the key exercises that you wanted patients doing during recovery, and had those videos on my hip and knee. Because 7 years ago, it wasn't common at all. I think, you were lucky as a patient if you got a booklet that had photos or illustrations. And so your team was very early on in video. I think even before, organizations were putting videos on YouTube for patients. I don't think that was happening a lot 7 years ago. So was there anything about video in particular that you remember back then that it just made sense to your team?
Well, I think for us, the issue was that as length of stay were getting shorter, and patients had limited access to post-op interaction with our rehab team, we recognized that they would do an exercise a few times and then head off and try to replicate what they were taught. But what we found when people came back to clinic was that they were not doing the exercise the way they were taught. Mm-hmm. They were accommodating to different habits. So for instance, in recovering from hip surgery, they wouldn't actually be exercising their hip abductors properly. They'd be using some accessory hip flexors or something, and then they'd wonder why they were still limping. And so, what we wanted to do to provide them with a visual image of what they were taught, with the exercise being done properly, with the therapist describing exactly how to position your foot, how to position your body, etc., so that the patient would have visual clues to understand how to do the exercise properly. And, I think everybody learns a bit differently, but for most people that are learning a skill, and recovery from surgery is in fact learning a skill. You are learning how to use your hip again. You're learning how to use your knee again. And I think for most people, seeing somebody doing an exercise properly and being able to look at that as many times a day as you want, or as many times a week as you want, allows them to try to replicate that and recover more rapidly because they're doing the exercise properly. Mm-hmm. So for us, it was just a matter of, well, the physio can't be there in the room with you. Let's show you how to do this exercise, and you can access it whenever you want. Morning, noon, or night. You get up at 3 a.m. and you can't sleep. You want to do some exercises, turn on your video and do some exercises with your therapist.
Mm-hmm. I love that. And I think one of the powerful things is that you actually had your own team film the exercises, the same team that the patient would be interacting with at the Holland Center, because you could have frankly, you could have gone in any random video of an exercise, but I think it's probably pretty powerful when patients know, oh, wow, this is, Amy from the Holland Center. Like I've met her before, I've worked with her, I know that this is the right exercise to do. It's vetted by the Holland Center team. And I can see that must be a pretty important differentiator for patients, that trust,
Well, it was. And in fact, although sometimes we got more calls than we wanted to, when patients were really struggling and they could see the therapist that they'd worked with they could actually call the rehab department and say, could I speak to so-and-so? Because I worked with him or her in the hospital, and I'm just not quite getting this. I'm looking at the video. And so, you know, that ability to relate to someone that helped you initially in your post-op care, we thought was really important to see a familiar face, not just a drawing, you know, animation, real live person that you actually saw in the hospital that's trying to help you.
Right.
I love that. Alan, I have one more question. I don't mean to
no, it's okay.
Monopolize the all the questions, but one of the things I've really loved about working with the Holland Center is that your team has been so positive in how you celebrate milestones. So for those who don't know, whenever there was a big, I guess, milestone with my hip and knee. So for example, I think when we first launched it, in the Holland Center lobby, there's a whole celebration. I mean, your team you actually had, I think a cake design with my hip and knee on it, and everyone came to the lobby, and it was a big thing. And your team really took the time to invest in celebrating, you know, that milestone, and a few more happened along the way in the partnership. I got to tell you that's not a very common thing. Like, I mean, we work with a lot of healthcare organizations, and there's a lot of, you know, let's call it internal, like, hurrah, like we did this within the team, but not as much, hey, let's go to the lobby, let's share this excitement with the rest of the organization. Did you know that that's not a common thing, or region? Like, it's not, I can tell you from our experience. I love that. Like, how does that happen?
Well, I didn't know what's common or not common, because I don't really go and see how things get launched at other hospitals. But, you know, we always felt that these innovations were a hospital innovation. They were, everybody was contributing to it, you know. So sure, we were developing something specific with a specific team to develop this app and to make it good. But, you know, particularly at our place where it's a smaller center and everybody takes pride in the center, you know, we felt that everybody that worked there should understand that we've developed this and that they were part of it. That, you know, that they're helping us to help patients to get better, pointing out to us sometimes when patients were having difficulty. All those little things contributed, right? And I think that the more that an organization, the people, I'm not talking about the executives, I'm talking about the people that work in the organization that are on their feet day after day, helping, you know, that often feel that they're doing their work and not feeling valued. When you share these successes with them and help them to feel as part of the contributing team, the morale, it really boosts the morale of the place. You know, everybody feels proud of what the organization is achieving.
And I mean, I think a testament to that is the fact that, you know, celebrating those wins, big or small. I mean, I'm talking about this years later. I'm remembering the cake. I mean, I think to some people that might seem like a small thing, but it's very memorable. You know, I've taken that away myself.
Yeah, it was a great day. I remember it as well, because it was an awful lot of work for us to get to that point.
Yeah.
And but there was a huge attendance. I mean, again, it's, you know, people felt that they were part of the team, even though they weren't part of the small team that developed it. They understood that this was an accomplishment of the organization and not just of a small group of people that were taking all the accolades for themselves.
Amazing. Alan, I'll pass the baton back to you.
Yeah, that's great. So Dr. Gollish, you are also collecting patient-reported outcomes using the technology, you know, such as pain scores, joint range of motion, opioid use, things like that. Why did you believe, or why do you believe that PROs, or patient-reported outcomes, are so important?
Well, you know, they're important because for so many years, our judgment of outcome was based on the surgeon's impression of how well the patient was doing. And of course, that's very biased, particularly if you're the surgeon. Mm-hmm. And so, you know, it was hard to understand whether the patient's perspective of the quality of the outcome and the surgeon's perspective of the quality of the outcome had any relationship to each other. And so understanding how patients see the quality of their journey through their surgery is really important in order to improve the quality of that journey. And sometimes the outcome, you know, the patient-reported outcomes do have their downsides to them, but they have their upsides as well. One of the things that we have learned in using the app, because we've had such a high volume of people use it, is trends in outcomes, right? And that has actually helped us in looking at the patient-reported outcomes in terms of opioid use, ranges of motion, timelines in terms of improvement in range, improvement in walking patterns, to modify our rehab protocols and our prescription protocols to pattern, in a sense, after what patients are experiencing, and trying to change that curve to improve the earlier stages of their journey. And that's really been very informative for us to be able to review that and to use that real life longitudinal data that patients are putting into the app as they use it. And it has, over time, allowed us to improve the quality of the outcome.
Right.
So patients have been helping themselves. And I think that the nice thing, and when we do talk to people about the value of participating and using the app, is it's going to help you, but it's also going to help people next year and the year after and the year after, because the more people that use it and the more information that we can see to understand patients' journeys post-op, the more we can adapt our protocols to try to improve that journey.
Right. I think another point is, with any surgery, expectation setting is so important with patients. And so I imagine, collecting these PROs probably helped you and your team set proper expectations. If you know the range of motion trajectory post-op on average is going to be, X, Y, and Z, maybe it also helped with expectation setting.
Absolutely. I mean, everybody's recovery is different, and patients are always asking, what can I expect at a certain stage of my recovery? And of course, it's hard to be patient specific because everybody comes in with a different set of functional parameters to start with, right? But by looking at the outcome for thousands of patients, we can give people an idea of what the average is, what the sort of worst is, what the best is. And part of the value of that is actually understanding what the worst is, so that we put those markers into the app, so that when we see that people are struggling and we understand at what level they're struggling, we can put in a notification in the app. We don't say you're in the bottom quartile, but we know you're in the bottom quartile. So we're saying, if you haven't achieved this by 10 days or 14 days, you need to contact your surgeon. So that we don't leave people to be floundering and show up for their 6-week follow-up visit in a state that we could have avoided. And that's been one of the big values of the app, is for people to be able to monitor their own journey as they recover, particularly in the first 2 to 3 weeks, when we see patients that are going to do poorly get better a little bit in the first week or so, and then they really drop off and get worse. And the notifications in the app to remind people of where they should be based on what we've learned from other patients has been incredibly valuable in avoiding poor outcome by catching patients who are doing poorly sooner rather than later.
Mm-hmm. That's excellent. Josh kind of mentioned this in the beginning, but due to COVID, we've seen a major backlog of surgeries. And so I'm curious, where do you see the role of platforms like My Hip and Knee playing to help increase same-day discharge or same-day surgeries, or to reduce length of stay and help with that backlog?
Well, it's kind of two aspects of the backlog, but I think in terms of the value of this type of platform, it does give people the confidence to be able to manage at home sooner than they used to be able to. So when we had, the information that's available to them on the app used to take us 3 to 5 days to get it into them.
Right.
And we didn't really have any way of giving it to them otherwise, and any information from them to take home. So it took them, quite a while to be comfortable with their new joint, their ability to get in and out of bed, and what's good and what's not. So, in terms of the shortened length of stay, for sure, the ability of the patient to have something like the My Hip and Knee app really gives them the confidence, and their coach, whoever is helping them at home, to be able to manage at home safely sooner and get out of hospital sooner.
Right.
The surgical backlog issue is a different issue. I mean, there's only so many operating rooms. There's only so many hours in a day per operating room, et cetera. You can extend the hours, you can work on weekends, you can do all kinds of things. But we look at it as an operating room and a surgeon and a patient. That is the small part of the team. There's the nurses, there's the cleaning staff, there's the people that have to sterilize all the equipment that we use to do the surgery and so on. And so when we look at managing the backlog, we have to look at everybody from the people that mop the floors after the surgery to the people that are doing the surgery and the patients. So on that whole team has to be taken into account as we tackle this backlog. And it's going to be a major challenge for sure. The advantage of having an app like this is that you shorten length of stay so that your flow through is much better, as long as the hospital doesn't take some of that efficiency by closing beds, right? So, but at the end of the day, a certain percentage of people will be able to have their surgery as same day or less than a 24-hour stay in hospital, and a percentage will be able to have one overnight stay, and then some will need a little bit longer. But regardless of length of stay, the device, an app like this, is useful to anyone once they go home.
Right.
And I think it will help from the backlog perspective simply by allowing more people to have same-day surgery and not use in-hospital resource. There's a lot of issues associated with that, but simple answer is yes. Having this type of app does help people to get home safely and confidently sooner than they would be able to otherwise.
Right, but it is certainly a complex circumstance with many variables at play.
Many variables, yeah.
Yeah, makes sense. So I'm curious, now that Canada, for instance, is opening up more and more, what aspects of patient communication do you think will stay virtual as we've implemented and maybe, replacing some in-person things? And what do you think will go back to being face-to-face?
Well, I think that, stable patient situations that can be discussed, and a lot of it is just a conversation, a hand-holding exercise in a sense. I'm talking particularly about orthopedics. Can be virtual, just giving them the confidence of someone having questions about medication, swelling, things like that. But a lot of what we do with patients on a one-on-one in-face visit, a face-to-face visit, is examining the patient. Patients say, well, my knee is sore. Sometimes it feels wobbly, and examining the patient, feeling the knee for instability, feeling the hip for range of motion, feeling the hip abductors to understand why the patient is struggling. Are they intact or not? And again, I've been in practice a long time. When if you say to me, well, how many knee examinations did you do throughout your career? Like it might be somewhere in the 100,000 times I've examined somebody's knee, right? And so I worry a little bit for our junior colleagues and our younger surgeons not being able to have the advantage of repeated over and over and over examination of knees and hips and shoulders and everything else, whatever your subspecialty is, to understand what's perfect, what's not so perfect, what works for a patient, what doesn't work for a patient, why is this patient having trouble. And so, I think that we have to be careful not to lose the skill development side of repeated ability to practice your skill in examination, practice your skill in examining the patient, and then explaining to them exactly what you found when you examined them. So, for instance, if someone, they live a long distance, they're doing a virtual visit, they say, well, let me show you my knee. And they show you their knee and they say, I don't understand why, it's not bending well, or why. And, so how much can you tell them, right, without examining them, right? So it's every specialty is different. You know, there are many things in family practice, in non-physical examination specialties. You know, as people have things at home, measure their blood pressure, they measure for a whole variety of things. That information is sent to the physician. Those sort of things are, you know, can clearly be managed virtually and save lots of time and travel and all those other things. But there are specialties like orthopedics where developing a skill set in your hands is critically important for continuous education for yourself and continuous improvement in your ability to provide good care. So I think it's a process in evolution for people to understand what visits are important, what visits aren't. And I think time will tell us how many fewer how many fewer in-person visits we can have while still achieving the same outcomes and the same patient confidence in their surgeon. I mean, a lot of the confidence people have in their surgeon is in relation to the face-to-face contact they have with them, both pre and post-op. And, you know, not everybody gets a great outcome. There's no question about it. But sometimes the most important part of helping the person to understand where they're at and what their future looks like is sitting down with them face-to-face, being empathetic and understanding their situation and trying to explain to them things that they can do. And I think that human touch has to continue, but doesn't have to happen with every visit. You know, we used to see people at 6 weeks, 6 months, 1 year, etc. We don't need to be doing that, but we can't stop being humans and having human-to-human interaction.
I think that's a fantastic point, Dr. Gollish. It kind of reminds me of this idea that, you know, telemedicine now, yes, it's more prevalent. People are more accustomed to it since the pandemic, but it's one additional tool in the toolbox now. And so it's up to us to figure out, well, what are the situations in which it is the right tool? And sometimes it is, but sometimes, to your point, it's not. And it's not about trying to digitize every interaction with the patient. It's about about contextual aspects, like what's right for this situation and doing what's best for that patient encounter, which, to your point, could be in person, or maybe now there's a few more things we can do virtual, but it's never going to be a one-size-fits all solution. That makes a lot of sense.
Well, I think we have to see, you know, again, it's especially specific, but we have to see this as an adjunct to care, but not a substitute for certain types of care. Mm-hmm. And, you know, and I think that the two can complement each other in a way that make the patient's journey better.
Right.
But we have to be careful not to make the patient's journey worse. And so we have to know when the adjunct to care isn't enough and we need the person-to-person care. And again, going back to experience, if you grow up, in a sense, I guess, in your practice early on with just virtual care, the red flags for you may not necessarily be there because you haven't had enough person-to-person contact. And so I think we have to be a little cautious of that. I think that there's a great tendency now to want to avoid people having to travel. And of course, in Canada and with our geography, travel can be, and our travel can be impossible. So, this is a great adjunct to care. If I have you have a patient who's come to you to have a knee revision, and this is a big part of my practice, and from all over the province, and they're 300 kilometers away, and it's a snowstorm, and they've got an issue, and I need to see it. What a great platform to do that. But at the end of the day, if it's a significant issue, and I say, look, try the, I think this is what's going on, but I really think once the weather gets better, I'd really like to see you in person so that I can make sure that we're not missing something.
Yeah. Josh, did you have any other questions?
No, this was fantastic. I mean, I do have the fast 5 questions, yeah. But before that, no, I think we covered all the major topics with Dr. Gollish.
Yeah. Agreed. So Dr. Gollish, this next section is what we call the lightning round, or the fast 5 questions. Basically 5 questions to get to know you a little bit better for our audience. So I'll start with the first one. What is your favorite book or book you've gifted the most?
That was a good one. I was thinking about that, and I think one of my favorite books I've read in a long time is called A Gentleman in Moscow, written by an author called Amor Tolles, who also wrote a book called Rules of Civility.
Yeah.
It's the writing is excellent, and the journey of the gentleman in Moscow is something that teaches you about life, and I highly recommend it. It's a really great read. The quality of the writing is absolutely superb. Great book.
I have added it to my list. That sounds good. Question 2, how has an apparent failure set you up for greater success?
Well, that's so with everything we've been talking about in terms of innovation and so on, one of the reasons I think we've been successful is because when I first joined the Holland Center, or the Orthopedic Arthritic, quite a while ago, and was appointed the head of the Arthroplasty service, I made a presentation to some of the executive about becoming, in a sense, a center of excellence for joint replacement. And I didn't do a very good job of it, quite frankly. I didn't have enough data. I didn't have enough business case. I didn't have anything. And what I got back from them basically was, we're just going to leave things as they are. We're really not interested.
Mm-hmm.
I went, no, you're just not understanding the opportunity here. So what I learned and used as I moved through as medical director and so on, if you're coming forward with something and you want people to think about innovation or change, make sure you have all the information that you can, right, and moved on to be successful. But that was a good wake up. It's like, don't come and waste our time. If you're gonna waste our time with a vague proposal, go away, and we'll just continue on with what we're doing, because you haven't got our interest.
Yeah, I appreciate that didn't deter you, because in the end it did actually turn out to be the center of excellence, and you did go through.
I actually think that's a great test, and I don't know if it was intentional or not by the executive, but it's like, hey, if we push back on Dr. Gollish's idea and then he just says, okay, and moves on, then maybe it wasn't that important to Dr. Gollish in the first place. But the fact that you came back with like, no, like, this is really important to me, then the executives say, oh, okay, like, he's serious about this. He's not backing down on this topic. So,
yeah.
Well, and it having learned that early on paid off in over the years many times, in terms of making sure that we had adequate resource and adequate funding for things, by presenting the numbers, the business model, et cetera. So I learned my lesson. Come prepared.
Mm-hmm.
It reminds me, like, one of my favorite sayings is like, the hard work is actually in the preparation. It's kind of like if you're performing on, on Broadway, I'm like, all the hard work really is before the performance. It's like, if you've practiced this a million times, it like the back of your hand. The performance is the easy part. It's when you haven't put in the preparation that when you get on stage, that's the hard part then. But if you've done your homework, it's the performance is the easy part.
Mm-hmm.
Yep.
That's great. So question 3, would you rather have super strength, super speed, or the ability to read people's minds?
Oh God, I wouldn't want to read people's minds. That would be terrible. Probably super strength.
Nice. That's good. Question 4, what is something in healthcare you believe that others might find insane?
Well, I think I'll go back to what, talking about a bit earlier, in terms of, having done this for a long time. One of the surgeons who's basically lived through the entire evolution of joint replacement from the late 70s to now. And, with people looking now at people going home the same day, et cetera, people would, find insane. Like, when someone had a total knee replacement, we would put their leg in a cast for 4 weeks. Huh. Like, we wouldn't let them move their knee for 4 weeks. Like, I don't know what we were thinking, right, but that's what we were told to do by the people, from the early 70s who had started doing knee replacement. People had a hip replacement, they would be in bed for a week. Wow. We wouldn't let them get up. They had what we called slings and springs to support their leg. And, you know, you look back at it and you go, it's no wonder we had a high incidence of blood clots, right?
Right.
People could, but, you know, sometimes, you know, the insanity at the time, it doesn't seem insane, but you look back at it, you go, I don't understand why we did that. Like, why did people think we should do that? You know, I was trying to think of something that might be insane going forward, but you know what? I'm not sure anything's insane anymore. Like, I think there's just so many possibilities of what people and scientists are going to be able to do over the next decade or two or three, that, you know, what we think is totally out of the realm of possibility and that's never going to happen. You can never say never anymore.
Dr. Gollish, something now I'm curious about. So it sounds like, and I think this is true not just in, you know, in medicine, but in other industries, where learning the history of something teaches you a lot about how to think about the future. When someone's coming in and doing, you know, an adult reconstruction fellowship, let's say at the Holland Center, is there a part of the curriculum where you're saying, hey, you really have to learn the history of, you know, how total joints have evolved over the years, you know, where we started, you know, decades ago, where we are now and how we got here? Is that part of the curriculum at all?
It's not. It's not. It's a very good point, you know, and interestingly, you know, my fellows over the years, they would say, well, how did you learn to do this? How did you know what, you know, and I'd start to tell them about what it was like when I first went into practice, and so on. And they would be astonished, right? Absolutely astonished. Like, for instance, I'll give you an example. Total knee replacement evolved in the late 70s, early 80s. We didn't have total knee replacements that were specific for the right or left knee until the early to mid 1990s, right? We did total knee replacement. It was a unisex total knee. There was no right or left that you put on the femur. There were three sizes, small, medium, and large, and the same on the tibia. But there was no side. And when I tell my fellows, you know, that, well, we didn't have a right or a left, and we didn't have 8 sizes to choose from. And so when they look at you, and I say, but that's all we had, right? That's what there was. And in my office at the Holland Center, I actually have kept from the 80s, late 70s, and into the 80s, some old clinical orthopedic journals and so on, so that they can see what life was like. How did we do this in the 80s? So I do encourage the fellows to just, you know, take this home, just look through it, just kind of see what life was like 20, 30 years ago. The things you aren't going to have to live with now, because we moved everything to where it is today. But it is really important for them to understand. And part of that is just not repeating the bad parts of history, right? You know, like, we tried that 20 years ago, it didn't work, don't do it again, right?
I think the other part is almost like it gives them inspiration to, you know, believe that, hey, you know what, there's always room for improvement. I mean, even just in total joint replacement, there's been so much improvement and innovation over the years, and it doesn't have to stop. You know, maybe inspires them to think about what they can do to contribute to the future of the field.
Absolutely.
Yeah, that's great. So last question that we have, Dr. Gollish, this is a COVID-19 lockdown related question. What is one hobby or activity you've gotten into since the beginning of the pandemic?
Well, I'd say probably the thing I've done the most is, and partly because I was in the process of retiring, was to get back to looking after myself and, you know, my fitness regimen and so on. I know a lot of people have, you know, that's what a lot of people have done, you know, during the pandemic, but we, you know, as with many people did, got a Peloton, and, you know, we've got an exercise room, and you know, I've always enjoyed and you know, keeping fit and staying active. But I think, you know, one of the things you recognize as you get older is that staying fit and active improves your quality of life, and hopefully for a long time to come. So I just thought, okay, I've got the time now, and I don't have to worry about, you know, I'm too tired from operating, or I've got a meeting to go to, or I've got this or that. Let's get into, you know, looking after yourself a bit better. So that's basically been my COVID change, and it's I've enjoyed it, and it's I think it's helping me to be able to stay fit and active, and be able to continue to do the things I like to do, like, you know, going skiing, playing golf, and running around with my grandchildren.
Oh, that's excellent. Were you always a cyclist or?
No,
Okay.
no, I wasn't a cyclist, but my fitness activity cardio was always cycling.
Yeah.
I never liked running,
Yeah.
particularly, and obviously having a good bike that you can use allows you to use it all year round. So it's again, I think it's a lot of people have taken up cooking and sewing and knitting and all those other things. And I decided I wasn't going to tackle anything like that. What I really needed to do was look after my physical health and it helps your mental health as well. I think, being physically fit and active. So I'm going to keep doing it.
Oh, that's excellent. That is good. And I imagine the benefits on your joints as well. So it was cycling as opposed to running on a treadmill. So that's fantastic. Well, Dr. Gollish, that's all the questions that we had for this podcast, and it's coming up to the hour now. So I just wanted to thank you, honestly, for coming on the show and sharing your years of wisdom and years of experience in the field, and really being a pioneer in the industry and across Canada and across the world, frankly, with our audience. So thank you so much for joining today and sharing your wisdom with us.
Thanks, Dr. Gollish.
Thank you both very much. And I wish Seamless all the best in its future endeavors.